to using AHP's benchmarking data webinar. My name is Jasmine Jones, and I am the research specialist here at AHP, and I will be moderating our discussion today. Just a few housekeeping items before we get started. When you enter the call, you will automatically be put on mute, and if you could keep yourself on mute, that'd be great. I'm going to make sure that we can hear each of what our presenters are saying and prevent any background noise. Second, we will be taking questions for each of our participants, as we want this to be an interactive experience for everyone listening today. As we go through the agenda later, I'll explain more on when to submit these questions, but on the right side of your screen, you should see a text bubble that you can click to type a message. If you'd like to ask a question live, please make sure at the very bottom of the chat you have either everyone or Jasmine selected instead of one of our presenters, because I'll be the one that is gathering those questions. Also, if you have any questions about any technical issues that you're having, feel free to select Michael Eggert's name in the chat and he can help you out that way. Last, we are recording the webinar today and we'll be sending out the link to view it on YouTube a few days from now so that you can share it and reference it for later. So just to let you know what we're going to cover today, first we're going to do a quick overview of this year's report on giving and give some background about benchmarking before we get started. Next, we're going to hear from each of our presenters in the order you see here. After each person presents, we'll have some time for any questions from the audience. So if you have a question while someone is presenting, please submit it in the chat box so we can see it. In case you miss asking a question from one of our presenters, we'll have a general Q&A period at the very end. So for example, if you have a question for Nancy, but you don't think of it until Tamra is presenting, then you can still submit that question and we'll get to it at the very end. Another note on this, please make sure that you specify who your question is for so that we know who you're referring to. Lastly, we'll end today with a few closing remarks and contact information in case you have any questions after the webinar. So to start off, we're going to do a quick overview of the report on giving for context of what we'll be going over today. If you aren't familiar with the report on giving, it's an annual report that AHP has been doing since 1984. This year, we released the 34th edition with help from our partners at Association Research, Inc. and Peer Focus. This report includes data about fundraising performance and healthcare philanthropy, and we gather this data through a yearly survey that we distribute to members and non-members from a range of different entity types and sizes in the US and Canada. This year, we had 210 US participants and 34 Canadian participants, and this number is growing every year that we conduct this study. This published report is now available online to all of our members and prospects, but if you did participate in the survey this year, you get a complimentary copy. If you have any questions about how to access that copy, feel free to reach out to me. And again, my contact information will be at the very end of the presentation. Next, I'm going to review some high-level metrics from this year's report. So for total funds raised, we estimated $10.437 billion was raised in fiscal year 2017. This is an increase of 2.9% from the fiscal year 2016 estimation of $10.3 billion. Return on investment, we found a median of $4.03. Here we saw a slight decrease from last year's median of $4.06. And in cost to raise a dollar, we have a median of 25 cents, which is about the same value that we found in fiscal year 2016. Now we're going to do a quick rundown of each level of benchmarking for context. All participants of the survey have access to a free performance scorecard, and I'll go in depth about this in the next slide. In the next level, we have a basic subscription, which includes the scorecard along with 4 additional reports on 5-year trends, a summary of survey data, management monitors by program type, including total production, return on investment, and cost to raise a dollar. At the highest level of benchmarking, we have an advanced subscription, which includes the scorecard and basic subscription reports, but also includes 20 additional reports that break down the data by program area and survey section. And here's a sample of what the scorecard looks like. Here you can see return on investment, cost to raise a dollar, net fundraising revenue, net fundraising returns per direct staff FTE, total fundraising expenses, and total endowment values. Pretty much you start with selecting a comparison group, either a pre-created one or one that you make yourself. And next you would select which fiscal year you'd like to look at. And when you run your scorecard, you'll see your organization's data in the yellow against percentile values of your comparison group. So here you can see we're comparing our demonstration hospital data to all participants from the 2018 report on giving, and we're looking at their data from fiscal year 2017. So this is a really good starting point for our survey participants to get an overall snapshot of where they stand against a comparison group and which areas they might want to investigate further. Before we get into our main content for today, I'd just like to take a moment to introduce our 3 presenters. All three of them are members of AHP and a part of the AHP Standards Council, so they're working with other members and our staff on our reporting standards, and they're working right now on revisions to the current version of the standards manual. A lot of work has been put into this project so far, and these three have really helped us move towards making some really amazing changes for the standards manual and to the Report on Giving survey, so we're really thankful for them. First, we'll have Nancy Gregovich, Foundation Operations Officer at Intermountain Healthcare. Next, we'll hear from Tamra von Schroeck, Senior Director of Operations and Finance at Dignity Health Philanthropy. And last but not least, we'll hear from Carrie Boardwick, CFRE, Vice President of Philanthropy Operations at MedStar Health. And as we get into today's discussion, we really want to hone in on the point of why we're actually benchmarking our data, no matter who we're comparing ourselves to. We have this quote for you from William Edwards Deming from, he's an American statistician and engineer from the 20th century, and he puts it plainly saying, without data, you're just another person with an opinion, which is true in every aspect of our lives nowadays. We use data as a way to communicate with one another, whether it's your own team or partners of your organization, and that's really what we'd like to get into today. So I'm going to pass things off to our first presenter, Nancy Gregovich, who will give us a little bit of background of measuring performance in this industry and how her and her team handle this. Nancy?
Great job, Jasmine. Thank you so much. So first slide here, I want to talk about some of the key challenges for measuring performance in healthcare philanthropy. So first bullet, we work in an industry that is driven by metrics. Virtually everything in healthcare is measured in some form or another. And I actually did a little bit of research in preparation for this, and in particular, thought about hospital quality and some of the CMS outcome measures for hospital quality. And these are items that all of our hospitals or healthcare organizations get measured on an ongoing and consistent basis. So hospitals get measured on mortality, safety, readmission rates, patient experience, effectiveness of care, timeliness of care, effective use of medical imaging, and so on. This is just one set of measurements that our hospitals or our healthcare organizations are measured by. So next bullet. So in an industry, performance benchmarking data is fractured at best. So in our industry, in healthcare philanthropy, in a business that is metrics driven, we don't have reliable benchmarking data. So for healthcare philanthropy executives, we have common interests and goals, but we don't have a united voice to speak about what our goals should be in healthcare philanthropy. And without metrics, communicating the value of philanthropy is a challenge. It's a challenge as we're trying to talk to each other. It's a challenge as we're trying to talk to hospital executives or system leadership. We just don't have a common language. Also, philanthropy has not earned a broad acceptance as a strategic imperative in our health systems, which is to say that in some health systems, philanthropy is embedded into the system's planning and long-term planning, and even in some instances in its bond rating. But in other institutions, it's just sort of an extra, a little extra, depending on the size of your program and how effective it is. Philanthropy is also often an ancillary business that really doesn't have consistent credibility with our C-suites or our organizational leadership. And we believe that data, benchmarking, performance measurement, and so on can actually help us gain credibility with our executives. There's also limited advocacy for philanthropy in healthcare literature, which is to say that AHP has a number of publications and it communicates with its membership, but we don't have a wide distribution of healthcare philanthropy literature industry-wide, and philanthropy is not frequently mentioned in industry literature. So that's something that we would really like to help change. So when we talk about the industry and benchmarking data, there are a number of groups, and there are a number of groups that are doing benchmarking. So, for example, and Mike, you can just bring all these up at once. There's the advisory board company. They have a benchmark survey process. Obviously, the Association for Healthcare Philanthropy has a benchmarking process. The Association for Fundraising Professionals, the Association of American Medical Colleges, the Council for Advancement and Support of Education, the Health Management Academy, the Health System Philanthropy Leadership Group, the National Association of College and University Business Officers, and then of course there's the good old 990. So all of these groups have some form of benchmarking or reporting how we're raising money and what our expenses are. But we all do things differently. In some cases, it's very different, the way that we're counting money or accounting for money or accounting for our expenses, but we haven't brought our voices together to come up with one standard. And we really ask the question, why aren't we working together? And hopefully you'll gather from this today that there is an effort, and I would have to go so far as to say that AHP is really leading the effort to bring more conversation amongst the industry groups. So actually that's a good segue into the next slide, which talks about what AHP is actually doing. So through its Standards Council, the AHP Standards Council, AHP is looking to increase its reputation as the recognized source for industry standards in healthcare philanthropy performance measures, right? As Jasmine mentioned earlier, the AHP Standards Council is working on revising the standards manual to bring a second edition to the membership in 2019. Once that second edition of the standards manual is available, we're really looking for ways that we can drive adoption of that new standards manual, which will address a number of issues that were not addressed in the first edition of the standards manual. So if there are any ideas on ways that we can actually drive adoption, we'd also like to try to drive adoption by some other industry groups that may not have their own version of a standards manual. AHP Standards Council is also working with a health system philanthropy leadership operations group to simplify AHP's benchmarking survey process. So as a group of health systems attempted to go into the AHP benchmarking program all together, we found that there were some complexities to the survey process that, if simplified, might make it easier for other hospitals and other systems or other organizations to get involved, because right now it really is kind of a big effort to report to the AHP benchmarking survey. We also want to increase the report on giving participation. The idea is that the more data that there is, the more consistently that we're reporting our data, the better the data will be, and then the more we can benchmark against one another. And then the Standards Council also has a goal to increase the presence of healthcare philanthropy in industry literature. So we're hoping to get reference to the report on giving or to the benchmarking survey outcomes in news outlets across the country, and we're hoping to do that at least 4 times next year. So the next slide, as we talk about the AHP Standards Manual, what we're really talking about is the importance of data integrity. So historically, counting and reporting fundraising revenue and expenses has varied greatly. I know I've been in this industry for probably 15, maybe 17 years, and each shop that I have worked in has had a different way of counting and accounting for money, right? So there's the production model versus the cash model versus the gap-based model for reporting expenses and revenue. So really, AHP, the Standards Manual, is attempting to bring greater definition to how we should be counting. There's also portfolio management or moves and other fundraising activities that should be measured and reported more consistently so that we can understand best practices and we can begin to share best practices on a broader scale to increase our effectiveness. We're also seeing that, and I'd be curious to know from the people on the phone, not that I'm asking for questions, but I would be interested to know how many of the participants or how many AHP members are undergoing some sort of merger or acquisition. Amongst our health system peer group, we find that many of us are either acquiring new hospitals or healthcare entities and or adding foundations that we have to increase or that we have to integrate, which of course makes our systems more complex, and it makes everything, including data management and systems integration, more difficult. So in order to become more relevant to our systems strategic plans, we think that having more reliable data is a much, it will lend itself very well to us gaining credibility. And also, as I mentioned a few minutes ago, data-driven best practices and performance measurement are imperative to our success if we want to have credibility with our C-suites, and if we want to have credibility with our donors that are increasingly more savvy. So next slide. I've mentioned a couple of times now, and Jasmine mentioned the Health System Philanthropy Leadership Group. So Tamra, Carrie, and I should say MedStar, Dignity, and Intermountain Healthcare participate in a health system peer group that came together in 2011 for the purposes of benchmarking. So some of us, in talking amongst ourselves, realized that the AHP benchmarking survey was really designed for hospitals rather than complex systems. So we were at a point in time in 2011 where we wanted to start to understand how our systems were performing against one another. So we created a group, and as a group, we all agreed to go into the AHP benchmarking survey for the purposes of getting our data all into one place and reporting by consistent standards. So the reason that we mention this today is that this group, by joining the AHP benchmarking survey, has really increased the amount of data that is available in the AHP benchmarking survey process. So collectively, we are currently 12 systems. Normally we're approximately 15 systems, but collectively we represent about 400 hospitals with more than $65 billion in annual net patient revenue, and we raise more than $425 million annually in philanthropy. And collectively we have approximately 1,000 FTEs. So we do enter our data as systems rather than individual hospitals, but our data is there for comparative purposes, and we think that having more data there, having all of our systems there, really has augmented the amount of data that is available. And we've been working really hard over the last 3 or 4 years to refine the way that we are that we're reporting, which has actually led to our participation in the revision of the AHP Standards Manual. So just as a matter of reference, in case you're wondering, these are the names of the 12 systems that currently participate in the HSPLG operations group, or the leadership group. And today, we are 3 systems that are intending to show the way that we are using benchmarking data, or the way that we are reporting to our local leadership, or to our boards, or to our C-suites. So in the ensuing slides, you will see that each one of our systems is reporting differently, but we feel like we're all making strides and learning from each other and learning through AHP's benchmarking survey process how we can report more consistently and how we can learn from each other, what we can understand from the data, and how we can drive best practices. So again, in some instances, we're measuring and reporting internally. In some instances, and I think that it's Tamra who does more external reporting. It's important to our success and in bringing credibility to our business. It also drives investment in our programs. So when I get into my slides at Intermountain Healthcare, we're growing very quickly. And we're growing in a system that is trying to manage expenses like all systems, and FTE counts, as I'm sure many of you have experienced, is difficult. Managing FTE counts is a difficult thing in a healthcare environment. So in an organization that is trying to manage and in some instances shrink an FTE count, because we are able to effectively report our performance, we actually have an investment from our senior leadership to grow our team. So benchmarking and reporting enables performance measurement and management, which is also helping us lead to better recruitment and retention. So at Intermountain, when I first got here, we had gift officers that that were doing a very good job, but with additional investment in professional development and in measuring performance, we have actually been able to increase the effectiveness of our gift officers, and we have been able to increase our investment in them, including financial investment in them, to retain them and to retain their talent that we're developing. And of course, the last bullet here, greater professional participation enables greater reliability and improvement of data. So the next slide, why should you participate in the AHP report on giving or benchmarking survey process? We think that it positions the professional healthcare fundraisers for better results and better credibility. It will allow you to maximize performance through standards and the sharing of knowledge. It also supports AHP's strategic plan. This is a big part of AHP's future, and it will help distinguish AHP as a thought leader and a resource for data to the C-suites and decision makers. So I feel like I've belabored this point a little bit, but I'll say it one more time. Greater participation in AHP benchmarking and report on giving enables greater reliability and improvement of industry data. So next slide. And I think Mikey can bring these up all at once. I'm not going to read each one of these, but these are basically bullet points that have been pulled out of the AHP 2018 Report on Giving survey. So these are our key takeaways. And I should mention that the AHP 2018 Report on Giving actually represents data from the fiscal year 2017. So, and I think that this drills down into a little bit greater detail than some of Jasmine's initial slides. And I'll just pause for a moment and allow folks to look at these. So now I'm going to spend just a couple of minutes talking about fundraising at Intermountain Healthcare and some of the ways that we report. So first slide. I first want to talk about how we're organized. We are a very complex system. We have 23 hospitals across the state of Utah. Each one of our hospitals previously had a local foundation, a separate 501c3 that was raising money for its local hospital. In 2013, the CFO at Intermountain looked across the state and said, this is a very inefficient way to raise money, to have all of these separate 501c3 foundations raising money locally. There was a lot of variation in best practices. in the way that data was being used, in the way that discharge patient information was being used. There were separate tax IDs, tax returns, investment strategies, etc. So in 2013, they dissolved all of those separate 501c3s. Can you go back just a second, Mike?
Oh, sure.
They dissolved all of those separate 501c3s and created one Intermountain Foundation. But we do have local offices that report up to the system, and we have a System Chief Development Officer named David Flood. And David Flood supervises 5 different executive directors who are overseeing the fundraising activities in the local fundraising offices. We have, however, centralized virtually all back office functions. So we have one database. We merged all of our databases together. We have centralized gift processing. We have centralized gift acknowledgement. We've got lockboxing now. We've centralized annual fund stewardship, donor prospect research, etc. So the next slide shows how we're organized in terms of people. So I mentioned we have a system VP, then we've got 4 leaders, including a vice president, myself as a foundation operations officer, we have a campaign officer, and then we have a programmatic giving officer. So I just wanted to share this as a snapshot of how we are organized. And when I first got here, David Flood was the first employee of the central office. I was the second employee, and now we have 32 employees at the central office and approximately 55 employees across the state. So those local offices account for another 25 or so employees. So when we first got here, as I mentioned, the governance structure was very different than it is now, and the local executive directors were not reporting to one system chief development officer, but instead they were reporting either to a local hospital administrator or to a regional vice president of operations. And basically, those hospital administrators or vice presidents of operations were very good at their jobs, but they didn't necessarily know how to manage a fundraising executive. So when David Flood arrived at Intermountain and the governance structure changed and the authority, the alignment changed, we started to report to our system executives on how we were doing. So next slide, please. So when we started to communicate with our executives, we started to talk about how philanthropy can make Intermountain stronger. So just this past year, when we talk to systems executives and we talk about having raised $58 million in 1 year, and go ahead and bring up the next bullet, Mike. And if we net out our expenses, we're actually 20% of Intermountain's net operating income. So when you break it down into terms like this, there's suddenly an increased interest in what we're doing. So next slide. So Intermountain is actually quite stable financially, and we like to say Intermountain's always going to be able to keep the lights on and treat patients, but it's philanthropy that funds those extra things. We're funding the research and the big capital projects and the innovation and the equipment and technology and charity care for patients that wouldn't otherwise be able to receive care. So again, when we start talking with executives about the foundation and why the foundation's work is important, we talk about how we make Intermountain stronger. So next slide. This slide is actually what we use to show how we have grown from 2013 when we were raising, actually before 2013, we were raising about $16 to $18 million across the system. And it was primarily through events and through annual fund. We were raising just above $20 million a year if there was a big capital campaign, a bricks and mortar capital campaign. But little by little, since we have reorganized and centralized, we've bumped up year after year after year. And if you go to the next slide, we're looking to hit a goal of 53.5 this year, which is a little bit lower than last year. because we're preparing for a big system-wide campaign. And then in 2019, we're looking to raise $75 million as we're in the first year of that campaign. So, you know, when we're able to show our executives these trend lines, and we can show them that we start the year out slow and then we build and we're a fourth quarter business, they really start to understand that philanthropy is more than golf tournaments and galas and direct mail pieces. It's really about relationships. So this slide shows that while we've been growing our revenue, we have consistently kept our cost to raise a dollar at industry standard or below. And then the next slide shows how we are raising money by program. So we have a very consistent annual fund constituency. So we have about 35,000 annual donors and donors who give through special events, and we can count on that every year. It's been through measuring gift officer performance and training our gift officers and doing better portfolio management that we have been able to increase our personal relationships with individuals in the community who want to invest in Intermountain, and that's how we have grown our major gift program. So next slide. So this is just intended to show a sample of the gift tables that we develop when we set our goals each year and how we expect the money to come in, you know, how many gifts we need to ask for in order to achieve our goal. And then the next slide is an example of how we measure gift officer performance. So, you know, these are just 3 of the individual gift officer metrics that we track throughout the year to help us get to our goal. Next slide. And then referencing back to report on giving, Mike, if you want to bring up all of the graphics, I'm sorry that I should have had the animations a little bit better. So this slide shows how Intermountain does against other AHP members. So in the beginning, Jasmine referenced the high-level cost to raise a dollar and report on investments numbers. So this is how we fare against those, and this is one way that we report to our leadership in terms of how we're doing against other industry organizations. And then the next slide shows, again, sorry, this is a little bit wonky, how we're raising money relative to the way that our peer institutions are raising money by program. So these are just 2 examples of how we're using the report on giving to compare ourselves to our colleagues, or I should say other organizations in the industry. So that is all I have. And with that, I will, I guess, Jasmine, we are open to questions for any of the slides that I've just covered.
Yeah, we can go ahead and open things up for questions from anyone in the audience. It doesn't look like we have any questions just yet. So, you know, I have a question for you. Also, thank you for that presentation. It was really great. You know, I think it's interesting that you go back several years in your data. I think you went all the way back to 2013 and some of the ones that I saw. But I know a lot of other survey participants do the same, and, you know, it's really been able to help them make necessary changes every year. I know specifically in staffing mix, that's what a lot of people look for in their direct FTEs. But, you know, when you and your team are setting those fundraising goals to hit each year, how exactly do you set those goals? Do you find that you're using high performer data as a standard, or is it something where you're using like HSPLG as a reference, or is it more, you know, you're internally benchmarking and setting standards against yourself?
Yeah, that's an excellent question. I think historically, we have looked at whatever was raised in the current year and then increased it, you know, 3 to 5 to 10%, and then that would be the goal. But I think that since we have merged our databases and we have created a central office, we have screened our database. So we have, you know, tested it for wealth capacity. And then as we have trained gift officers and started to assign donors to gift officers, and we're managing portfolios in a more focused way, And as we're getting more clever about what our funding needs are and understanding how much the system needs us to raise in order to meet, some of its goals, we're getting a little bit more scientific than we've ever been. And those are the ways that we're doing it through wealth screening, through understanding gift officer capacity. And I think, if we were to add more gift officers, I think we have more capacity to raise more money, and then understanding what the system's needs are. So, and campaign goals, of course, factors into that as well.
Oh, yeah, absolutely. Well, thank you, Nancy. It was great. I appreciate you, opening us up today, doing your presentation on all of that. So next we have Tamra von Schroeck from Dignity Health Philanthropy, who will talk a little bit about internal and external benchmarking within her operations. Tamra?
Thank you so much, Nancy. That I'll echo was great information, a lot of information. I'm going to just plunge right in. I've got about 20 slides or so that I'm going to spend more time on than others. Some I'll spend more time on. So I think we should just get right into it here and show you Dignity Health's current geographic footprint for our hospitals, which will actually very soon change when we align with Catholic Health Initiatives, also known as CHI, which is scheduled to close, oh my gosh, in less than 3 weeks now, I think it is. So on 12/31, we will be a merged healthcare ministry with CHI. Currently, however, we have approximately, if you could go back just for a second, Mike, just want to explain a little bit more. We have 40 hospitals in total. This is just Dignity Health that I'm speaking about, with 4 hospitals in Arizona, 3 in Nevada, and 33 in California. Once we're combined with CHI, we'll be supporting as a combined philanthropy organization over 130 hospitals with over, drumroll please, 80 separate fundraising foundations in 20 states. So we'll be going from 3 states to 20. But for purposes of today, it is in this current context, our current structure, that I'll be sharing on the next slide how philanthropy is currently structured. So here we are, a visual, lots of color here. This is a big picture org chart for how philanthropy is structured currently. Throughout the system, we have about 180 staff people. It calculates to about 170 FTEs because some of them are doing fractional work, not just philanthropy, but some hospital administration work as well. And they're doing this work at 29 separate 501c3 fundraising organizations. And just as background about those 180 staff folks, they're all Dignity Health employees, and they're situated either at one of our system offices, of which we have 4, or they're situated at our local foundation. So to get a little bit to the color here, it's a bit complicated at Dignity Health. We like to make life exciting because of the 29 foundations, excuse me, although the bylaws of each foundation state their purpose is to raise philanthropic dollars for a specifically named hospital or hospitals, some of the foundations we control. Those are the 19 in green, meaning that Dignity Health is its sole corporate member, while some of them we don't control. Those are the 10 in orange or yellow, or however that's displaying on your screen, meaning Dignity Health is not the sole corporate member of those. They have a different governance structure. All this said, we do include every one of our 29 foundations in the philanthropy reporting and benchmarking that we do, regardless of whether they're controlled by Dignity Health or not. And the fact is the fundraising dollars raised by each is dedicated by law to Dignity Health. Each one of these foundations receives an operating grant, so we do pay all the expenses of these foundations. So we're just one big happy family, regardless of the governance structure. So we'll go on to the next slide. And actually, these next 4 slides, I'm just going to go through very quickly just to give you a sense of the size and scale of philanthropy at Dignity Health. And these slides will give you just a glimpse into the high-level information we do track internally. These slides look at the combined picture of all 29 of our foundations for both the previous 5 years and for the most recent closed fiscal year, which for us was the fiscal year ended June 30th, 2018. At Intermountain, they've got a calendar year end, and we've got we get to be busy in the summertime. This particular first slide depicts fundraising revenue. Just back one more second, Mike, please. This first slide is our fundraising revenue and our fundraising expense. So it's basically how much did we raise and how much did it cost us to raise it. We did have a record-breaking year in FY18 due to a $25 million gift that was recorded at one of our largest foundations located here in Phoenix, which is where I happen to live and work. And now we can go to the next slide, which is, for us, our bottom line, the meat of it. It takes the last two bits of information from the previous slide, fundraising revenue and fundraising expense, and nets them. In other words, subtracting fundraising expense from fundraising revenue to get to that real meat of it, what we call net fundraising revenue. We focus on increasing this year over year. We think it's the most important thing, more than we focus on cost to raise a dollar, although cost to raise a dollar is of course important, but we like to put it simply. We'd rather raise, just to use a round number, we'd rather raise $100 million and have it cost us $30 million to do that, a 30-cent cost per dollar raise while netting $70 million. We'd rather do that than raise, say, $50 million, spending only $10 million to do it. That would be a 20-cent cost per dollar raise, netting only $40 million. I shouldn't say only, that's a big number, but the delta between netting $70 million versus $40 million means we have an additional $30 million to do good work at our hospitals and our communities, and we think that's what matters most. Going quickly to the next two slides, very quickly. In addition to fundraising, we think the most important thing we can do is get that money transferred over to our hospitals. You can see our 5-year history here, and we'll talk a little bit more a little bit later, but I'll just lay the groundwork here to say that we really think one of our guiding principles for each of our foundations is that they transfer at least 2 times what their operating expenses are. It's important for 990s, and that's all I'll say for now. We'll talk about that just in a little bit. So we can go on to the next slide. These are our FTEs that I referred to before, and importantly, we like to look at how much fundraising revenue is coming in the door per FTE. This is not just the direct fundraisers that are out there asking for gifts, but all staff that support those fundraisers as well. And you can see in FY18, there's an $878,000 per FTE. Tells a great story when it comes time to ask for investing for more FTEs. So that's it for that. We could go to the next slide. I'm going to talk just a little bit about benchmarking against other health systems, and we'll get to benchmarking against all our foundations internally as well. But as is typical when gathering info, the data that we are able to get at, it's usually for us a year behind. In other words, although FY18 is behind us at Dignity Health, since our fiscal year ended June 30th, when gathering info, since many organizations do have calendar year ends, it works out that to be consistent, the info is always in the rear view mirror for us. So if you go to the next slide, what we have here is FY17 data, not FY18's. And these are known health systems, and they're not just the largest health systems in that health systems philanthropy leadership group that was talked about, it was referenced before. So for instance, we're a Catholic sponsored organization, so there are a couple similarly Catholic sponsored organizations out there that we know very well. So we do share info with each other, as well as with other local healthcare organizations who just happen to be in our markets as well. So this, what we like to do here is look at organizations that are similar to us in some respects and some not, some in our market, some not, some religiously sponsored, some not, with various organizational structures. And we find that there's many stories to be told by gathering this information. We find that the information supports investment in additional FTEs. The correlation is definitely shown there, and we can glean information regarding increased fundraising revenue per FTE. As you know, as newer FTEs mature over time, we can see the proof is in the pudding that the longer an FTE, a fundraising FTE is around, that fundraising revenue does come to fruition. I feel like we need to speed along here, so we could go to the next slide and talk just very briefly about the Chronicle of Philanthropy. This is another external benchmarking that we do. I think you might all know there's like 1.5 million charities throughout all of the U.S. And the Chronicle of Philanthropy does a survey where they report on the top 400 strictly based on fundraising revenue that's raised. And so while it's not, impact or efficiency or anything like that, we do find value at Dignity Health, and we found it's helpful from several perspectives. The first being the national visibility that it offers, and secondly, our board and hospital and foundation leadership, they just love the data. They love how it supports further investment in FTEs. Philanthropy is seen as a successful arm at Dignity Health, and it also supports our recruitment efforts for top talent. And we just like to see the movement from year to year to year, moving up and up and up. And we go to the next. This is also related to the Chronicle. In addition to the top 400 being all types of not-for-profits, they also further parse it out. And when you just look at hospitals and medical centers, you can see back in 2009, we were number 27 out of those. We're at number 16th. And we do think that once we're merged with CHI, we'll be in the top 10. So we could go to the next slide and then talk about some of the internal benchmarking that we do. There's going to be a lot of information on these slides. So if we could go to the next, try to get through these quickly. These are just some of the reports that we do on a monthly basis just to reduce clutter. I've taken the foundation names off. I don't list all 29 of our foundations. I've just got the top 10 here. But you can see we can rank. I can rank them from high to low. I can sort it so that I can see who had the highest variance compared to budget, who had the highest change compared to their prior year. And it really gives us a lot of visibility to see, I wonder if there are problem areas. Do we need to reach out to one foundation or the other because perhaps there's an issue going on. So this is for fundraising revenue. If you go to the next slide. This is our cost per dollar raised by foundation. I'll just mention we very much fully load all our expenses. Every single penny that can be allocated to the foundation is. So if there is something that the hospital or the system office provides as a service, that does get to the right set of books. So we know that our costs are fully loaded. So that's cost per fundraising revenue. And on a more positive, another way of spinning cost per dollar raised, which is just the inverse, it kind of tells the more positive story. It's the difference between saying you have a 50-cent cost per dollar raised. In other words, it costs 50 cents to raise $1 versus the story being if I gave you $1 and I gave you 2 back, that's I guess a more positive story to tell. So that's our return on investment slide. If you could go to the next. This is our transfers to the hospital. Again, compared to budget and compared to previous years, I can sort these in any way I want. Next slide, trying to get through these quickly. This is our transfers as a multiple. I mentioned already that we really try to make sure that our hospitals are transferring at least 2 times their operating budget. You can see these 10 foundations did, and I think there were maybe only 1 or 2. We all know there are sometimes very good reasons that the foundations can't transfer. The restrictions didn't get met for whatever reason. You can continue on. Our FTEs per FTE, you can see we've got a broad range. This is just our largest foundation has nearly 19 FTEs, and the 10th ranked foundation has 6. We have some foundations that have only 2. You can continue, Mike. And in addition to by foundation, we also have service areas, and folks like this particular, because of the green and the red, you can see right off the bat if something is going well, meaning they're over budget, or if they're under budget, and the vertical line that's going up and down shows how much over budget or under budget they are relative to their budget. So the larger the gap, the greater they're either over budget or under budget by service area. And then just to summarize, I mean, we've talked and Nancy laid it out well why we do it, and I won't go through that. I think one of the more fun things that we do is the kudos that we're able to do, and we have kind of a Oscar-styled event at the end of a fiscal year, and we use the internal benchmarking information in order to name who the foundation of the year is, who the top performing service area is. I don't have it here, but we've got the most improved foundation. It's all based on the information that we're able to gather. And so it's not all just business. We do try to have fun too. And I think that's my last slide. That was a lot of information, trying to get through it quickly.
Yeah, well, thank you, Tamra. I appreciate you going through that. That's awesome. You know, I know we were talking the other day of how great it is to have something like Philanthropy 400 because of how inclusive it is. So, you know, it's kind of sad to see something like that going away. But, you know, and what you've seen in both using public recognition as a motivator, like with Philanthropy 400, and using the sort of internal comparative dashboards as motivators, have you found one to be more useful as an incentive in your teams at Dignity? And if so, why do you think so?
Oh, you know, incentive, that's an interesting way to put it. I mean, from an internal benchmarking perspective and the peer pressure, because we're very transparent, we share this information from the top of the organization, and it's very widely disseminated. So the peer pressure to incentivize a foundation to do well is always there. So that's an important thing to consider there, but it's also equally as important from the external benchmarking perspective, the more from a investment to be able to make the case to invest in philanthropy. Internal is more for performance management, and that other, but look at how we're doing compared to others, and look how much better we could be doing if we had whatever the additional extra FTEs were. I'm not sure if that answered your question or not.
No, yeah, absolutely, it does. It really does. So, you know, thank you for that. I appreciate it. I'm going to go ahead and move on to Carrie now. Carrie Boardwick from MedStar Health, who will give us a quick rundown of her team's philanthropy model and its key performance indicators for this year. Carrie?
Thank you, Jasmine. So I know for the essence of time, I will move through these slides very quickly. A little bit about MedStar Health. MedStar Health is a 10-hospital system, and we are located throughout the Baltimore, Maryland area and the DC area. In addition to our 10 hospitals, we also have multiple physician practices and ambulatory care sites. What makes us a little bit different than Dignity and Intermountain is that we are not a foundation. We are actually a department within our corporate structure. We disbanded our foundations a few years ago, and that means we do not have foundation boards. So on each of the hospital boards, we have a philanthropy committee that helps to advocate and be a community resource for us, as well as at our system level. It also means that we do not have a transfer process because we don't hold the funds in a foundation account. As we receive our funds, they sit directly on the hospital net asset reports. So that's a little bit of a nuance. As you look at the next slide, that takes us into our organizational chart. So our Senior Vice President and Chief Development Officer is Bruce Bartu. And Bruce has been with the organization for about 10 years, and he reports directly to our CEO, Ken Samet. We have 5 senior level positions that report to Bruce. Those are our regional philanthropy officers. 3 of them are over regions within the DC and Baltimore area, and they have their major gift team within those areas. Then there's a vice president of transformational philanthropy. He's responsible for our principal gift efforts, our $1 million plus gift efforts, as well as our grants team and our corporate partners team. And then there's myself, and I oversee our central services. So our central services is comprised of our research, our database, finance, legal, HR, relationships, compliance, as well as our communications and our annual giving efforts. We don't have a large annual giving component, which I'll talk a little bit about later, but all of those positions that you see there report to our central services team. And similar to what you heard when Nancy was talking, we created a central services team to help with resources for our major gift effort and for our major gift officers to focus solely on building relationships so that our central services team can help with all of the back-end support. So looking at our next slide, really the purpose of what MedStar Philanthropy Group focuses on is our major gift effort. And we say that we're powered by gratitude, and I'll talk a little bit more about our gratitude model. we focus solely on building new relationships with the community and renewing and enhancing current relationships. That is our main priority. Looking at the next slide, you may have heard Bruce Bartu present before on our gratitude model, and this is our grateful patient philanthropy model. We have a very strong model throughout MedStar. Everyone, all of our clinicians have been trained, and that's our physicians, our nurses, all of our leadership teams, our boards, hospital boards, have all been trained in our gratitude model, how to hear, accept, and acknowledge gratitude, and then how to build that relationship with the philanthropy team. We know, and we've seen a lot of studies in philanthropy, how gratitude has the ability to improve physical and psychological health. So we think it's very important for our physicians to understand how important it is for them to recognize that gratitude and build that relationship with the patient, and then help introduce the patient to the philanthropy team. Taking us to the next slide, a few components of what that means for us internally. We have a writer on our team that we follow a just-in-time process. So we don't have a lot of case studies and printed materials that you might see in other organizations. What we do is we focus on a just-in-time model. So our writer focuses on exactly what that individual prospect or donor needs and creates pieces according to the needs of that particular relationship. We also have somebody on our communications team that hears stories of gratitude, captures those stories, whether they're through videos, they might be, we might share them on social media, we might share them on our website, we might share them in testimonials, printed pieces, but captures those stories of gratitude and actually libraries them so that we can use them in our presentations and our outreach to the community. And then lastly, we have what we call our gratitude evangelist, and that's not really her title, but we have somebody on our team that works as our education lead to help train all of MedStar on what our gratitude model really is, and also take that externally too, because a lot of folks will reach out to us and ask what that means, and she helps to create our educational content for the philanthropy team. She doesn't just focus on gratitude, she's actually expanding her role, but because that is such a large part of what we do have somebody in-house that helps to set up training sessions and educational opportunities for different departments throughout MedStar. Looking at the next slide, I'm going to talk a little bit about, we track both KPIs and individual performance metrics. The individual performance metric is a new concept for us at MedStar. While it's not new to most organizations, it is new here. This screenshot shows a 10-year revenue stream for us over the last 10 years. We look at both recognized revenue, which is our accounting revenue. This is following GAAP and FASB standards. And then we also look at our production revenue, because we want to make sure we're capturing all of the fundraising efforts that we do. So we are a production model, and that means that we are looking at our grants, our public grants, as well as our planned gifts that might not be irrevocable, but we want to make sure that we're celebrating the donor when they make that commitment, and we're recognizing the revenue when we can. Obviously, we know that we won't be able to record that revenue on the recognized line, and that might take a few years for that revenue to come through, but we do want to take a moment to celebrate that donor for making that contribution. Looking at the next slide, this is a similar slide to the other slide where you're seeing that you have the production revenue over the last 5 years, where we really focus on building that central model. And we have that central philanthropy team. We saw our major gift efforts from the production side increase by 54%. So we know that this is the right model for us because we've seen a large jump in our contributions. And the next slide shows a similar number, but on the recognized revenue, which is our accounting statements, and that is a 65% jump. And then taking into the next slide, we don't have a large annual giving program. So while we do have an employee campaign, and we do have a couple of annual direct mail pieces and a few special events, we really don't have a strong model in annual giving. That's by design. This slide shows that our major gift efforts account for 91% of our revenue last year, and approximately 89% over the last few years prior to FY18. And I should have noted, like Tamra, our fiscal year starts July 1st. So we really are a strong major gift effort, and that also includes our grants as well. Looking at the next slide, we break our major gifts into 3 categories. Major gifts start at $10,000 for us. Then we have our leadership gifts at $100,000, and then we have our principal gifts at $1 million or more. This slide shows, we also have a revenue slide very similar to this that's not included, but this shows that we want to make sure our volume is strong in these areas. So we track this year over year to make sure that we are capturing the same number of gifts, hopefully more, and this will help us obviously generate more revenue overall. And the next slide, we realized that we do not, when I started here about a year ago, I realized we do not track individual performance metrics, and we needed to do that. Our philanthropy officers requested it because they didn't necessarily know what their individual performance expectations were, and we had some consultants that have come through that have recommended that as well. So we needed to define what our criteria was for how to track and manage our moves management process. Recently, my team built or rebuilt criteria for our philanthropy manual and set some basic structure in place for our major gift officers so they know when they need to enter information into the Raiser's Edge and how we can track that. This dashboard just shows our proposals that we pull out of Raiser's Edge, so you can see the activity at each of the levels, what's in the pipeline that's currently being asked, what's pending, what was declined. We track this each month, and we can look in greater detail, at specific names and philanthropy officers assigned to that, but this just kind of gives you an overall snapshot. The next slide covers the portfolio strength. So last year when I started, I realized that we had some frontline fundraisers who had portfolios of 400 names and some that had 80. So we needed to right size our portfolio management. So we took a big effort to make sure that we removed names that didn't need to be there, brought new names in if the portfolios were not large enough. And this, while we do this at an individual level, this shows a snapshot to make sure that our portfolios are healthy and that we have enough people in each section that they're moving through the process quickly and efficiently. Next slide. And this is new for us. So as I mentioned, we didn't have individual performance goals. So we educated the philanthropy officers just last month on what our new metrics are going to look like, and that this is a snapshot for what we're going to be tracking. We don't have goals assigned yet because Bruce has given us a little bit of a grace period to get used to entering this information consistently over the next 2 months. Then our philanthropy officers will have goals assigned, and those will take effect officially in FY20, which will start for us July 1. So you'll see here, we want to capture how many referrals are coming in from our physicians and our clinician champions. So that's the first bullet. The second is the qualification. So of the referrals, how many people are we able to say are truly prospects in the major gift effort that we can move forward? And how many then do we remove and maybe put into our annual giving efforts? The next one is our invitations or our asks and our revenue for that. The final one is our closes or our acceptances, the revenue for that. And then we do track total revenue for our philanthropy officers because they do sometimes receive gifts that are not necessarily major gifts, but they want to get quote unquote credit for that. So we do have a section where we're tracking all overall revenue for our individual philanthropy officers. So I know I went through that really quickly, but those are some of our metrics here at MedStar.
Awesome. Thank you, Carrie. I know we got a little bit pushed for time there, but I appreciate you going through that regardless.
Sure.
It doesn't look like we have any questions here, but, I'd just like to say, again, I really like the emphasis on, showing your performance year by year the way that you do, but, also the concept of having those personal dashboards. Could you talk a little bit about that? What kind of pushed MedStar to start using these personal dashboards as a tool?
Sure. Well, I think really we heard from our own team that they needed to know what their individual expectations were. They knew what their goals were at the individual hospitals, the entities, but not necessarily their own performance metrics. So we designed these to help guide them in what the expectations are for them, as well as I think it really is the best practice for anyone with a major gift culture to have individual performance metrics.
I agree 100%. That's great. Well, I know we're a little pushed for time again here, but I'd just like to open it up for any additional questions anyone might have, just in case. I'll leave a second or two just in case anybody has any questions they'd like to submit really quickly. All right. Well, I don't think we have any right now, so I think we're going to go ahead and close out for today. I'd like to go ahead and thank everyone for attending today's webinar, and thank you again to Nancy, Tamra, and Carrie for joining us as well, and to Mike Eggert for hosting our webinar today. I hope that you've all been able to take some useful information out of today, and hopefully you'll apply it in your own practices. On this slide here, I just have my contact information in case you have any questions from today or anything in general about participating in the Report on Giving survey, the report itself, or benchmarking. And I've also included Mike Eggert's contact information from Association Research in case you have any questions from today's webinar or anything about the back end of the Report on Giving or any data cleaning that we do there. So yeah. Again, I'd like to thank everyone for listening in today, and we hope you have a great rest of your day.
Bye now.
Thank you, Jasmine.
Thanks,
Thank you.
Jasmine. Bye-bye.